Thank you. Thank you to the organizers for hosting us. I'll say, as my colleagues have, that the hospitality has been really amazing, and it's my first trip to India, so it's been a real pleasure to be here. What I'm going to talk about for the next 20 minutes is an emerging technology. It's one that I know is already in use in some of the units that you work in, and for some people this may be something that you've heard about but haven't used as much. We're going to talk about Amplitude-Integrated EEG, or brain monitoring, in neonates who are undergoing therapeutic hypothermia for hypoxic ischemic encephalopathy. I'm going to start out by briefly talking about the evolution of amplitude-integrated EEG use, where we are now in terms of, is this the standard? Should we be monitoring all of these babies? And how did we get here? And then I'm going to talk about the three main indications, or the reasons that people are using amplitude-integrated EEG during cooling, and some of the pros and cons of each of these uses. So right now, I practice in California, in the United States, and last year in California, the government that certifies all of our NICUs, that regulates the funding basically, said that if you are a NICU that's providing therapeutic hypothermia to neonates for hypoxic ischemic encephalopathy, you must do brain monitoring for the duration of cooling until that baby returns to normothermia. This is a pretty strong statement. It certainly wasn't the case that every hospital was doing brain monitoring during cooling, but it established a standard that now every NICU has to adhere to in the state of California, and it's increasingly becoming a trend that brain monitoring is recommended during hypothermia treatment. I should say that throughout this talk, I'm going to talk about amplitude-integrated EEG, which is sometimes abbreviated aEEG. Some people will call it cerebral function monitoring. Many of the early papers called it CFM. Right now in the States, CFM is a trademarked brand name, so we try not to use it too much. And there's many different companies that market these monitors. Some of them are standalone aEEG machines, like you see in the picture here. And some of them are software programs that you can use with continuously acquired EEG to process the signal and display it as aEEG. And the basic principle for people who haven't used this yet is that in the NICU, we monitor everything. We want to know how much volume goes in. We want to know how much volume goes out. I want to know about oximetry. I want to know about respiratory rate, carbon dioxide, heart rate, blood pressure. But what about the brain? Really, as more and more babies survive, there is more of an emphasis about neurodevelopmental outcomes. And the principle behind amplitude-integrated EEG is that it provides real-time measurement or assessment of brain function. And just briefly how this works. What I tell parents is that if we're doing an EEG, if we're doing amplitude-integrated EEG, we're measuring the brain waves. That's often a simple explanation that people can understand. What we're really doing with EEG, or amplitude-integrated EEG, is we're recording brain activity. And it's exactly the same as when the child has an ECG. You apply electrodes to the chest, you're measuring electrical differences across the heart to look at that EKG, showing you electrical activity in the heart. Well, with EEG, you put the electrodes on the head, and you're measuring the voltage differences or the electrical differences between places in the brain, and that's displayed graphically in an output. Now, with conventional EEG, what you have is something like you see at the top of the screen here, where you have on the head anywhere from 10 to 16 electrodes, and each of the little squiggly lines is measuring the difference in electrical potential between two areas on the scalp. With amplitude-integrated EEG, we want something that's simpler, something that's easier to use. And so only 2 or 4 electrodes is applied, and you get a much simpler recording of electrical activity. The intention behind this is that it's easier to put on just 2 or 4 electrodes. It's meant to be applied at the bedside by nurses, by neonatologists, by neurologists, at some hospital by the respiratory therapists. But the whole point is that you're not dependent on an EEG technologist or a neurologist to come and precisely measure the head to get it started. And so after you've recorded your 1 or 2 channels of EEG, you process that signal. And so if you look at this picture here, up at the top, one screen of EEG is about 15 seconds of brain activity, and it's giving you lots of detail about spatial information, what's happening in different parts of the head. If you look down at the bottom, one screen of Amplitude-Integrated EEG is about 3 hours of activity. So you essentially take this tracing and you scrunch it up quite a bit so that instead of looking on a second-to-second basis of what's happening with the brain, you have a trend over time. And you can look at the screen and say, well, yeah, overall this baby's been doing about the same, except something happened in this period here where it looks like there's a difference in brain activity. What you actually see when you're looking at the Amplitude-Integrated EEG is, of course, simplified. That's the whole point. The x-axis is time, and again, it's usually a few hours on a screen, and the y-axis is just the amplitude, the height of the waveform. So you do lose some of the detail. It's not like conventional EEG where I can pontificate, talk about it in rich detail for every single second, but you do get a lot of information, and it's much easier to use. This is another example of what you might see for Amplitude-Integrated EEG. This is what we use at my hospital. We record conventional EEG, which I look at when I'm down in the EEG lab. And at the bedside, we display aEEG, which shows us the trend over time. And what you get are some characteristic patterns that give you an overall reflection of the brain function for the child. So these are 4 examples of Amplitude-Integrated EEGs from term neonates who were being cooled for hypoxic ischemic encephalopathy. In the upper left, you have a baby who's doing quite well. The top 2 channels are showing you the actual EEG trace on a second-to-second basis. The bottom 2 in that corner are the aEEG, where it's compressed the time display, and you're looking over a few hours, and you can see that the brain functions pretty much the same over a few hours. It stays relatively the same. If you compare figure A to the one just to the right of it, figure B, that's a baby who has brain function that's not quite as good. The amplitudes are a little bit lower, you can see in the aEEG panel, and that's reflected in the EEG trace up at the top of figure B. Down in the lower left-hand corner, C, that's a neonate who's not doing so well. Now you have amplitudes that are much lower, and that's reflected both in the source EEG at the top and in the Amplitude-Integrated EEG at the bottom, where you can see that that dense line of activity, it's lower on the y-axis. It doesn't have the thickness that it does up in the upper 2 examples. And the worst that you see is reflected in the illustration in figure D. This is a neonate who had severe hypoxic ischemic encephalopathy, who had very low amplitude brain activity. And you can see that both in the EEG and in the Amplitude-Integrated EEG. This is mostly for people who like to take pictures of references. There are some detailed systems for grading the aEEG or scoring it for how severely affected the pattern is. And this is just giving some details of those 2 systems. I won't go into that in great detail now. So I told you there are 3 ways the Amplitude-Integrated EEG is being applied for neonates with HIE. The first one is to identify which babies should be getting cooled. And there's some benefits to this approach, but also some concerns. So it's certainly true that the first cooling trials, both the CoolCap trial and the TOBY trial, used Amplitude-Integrated EEG as a way of identifying babies with encephalopathy that should enter into the trial. And there's some advantages to that. Sometimes when you're examining a baby, you're not quite sure, is this mild encephalopathy, is this moderate encephalopathy? And so having the aEEG gave a more objective measure of brain function. It allowed people to have another way of looking at brain function to assess, was it severely impaired enough that these babies should get cooling? And so for those 2 trials, the aEEG, if it showed seizures, or if it was moderately or severely abnormal, that was bad enough that the babies got cooled. And so on the basis of that data from those 2 cooling studies, there are many hospitals that now use aEEG to help identify which babies should be cooled. And usually that means recording for 30 to 60 minutes and looking at that background pattern to determine whether or not it's bad enough that the baby should get cooled. But there's some concerns with that. And I think one of the take-home points I want to make today is that if you are using Amplitude-Integrated EEG to identify babies for cooling, it's great to identify which babies might be eligible, but there are some problems with using it to identify babies who look too well to get cooled. So for example, there was a small series of neonates, 14 babies. All of them had moderate or severe HIE based on their exam. All of them had MRI scans later. But of those 43 babies, 13 of them had aEEG patterns that looked normal when they first came into the hospital. And that's because with Amplitude-Integrated EEG, false normal recordings are possible. I'll explain why in a few slides. And for that reason, you shouldn't use Amplitude-Integrated EEG to exclude neonates for cooling. It's fine to say if the aEEG is abnormal, that's a baby that I'm going to cool, but I would really resist the temptation to use Amplitude-Integrated EEG to say, well, that baby's fine, we won't cool that baby. There's some people who argue you shouldn't even use it to identify the babies who are going to get cooled because it may not add much beyond what you see when you examine the baby. This was a paper that came out in Pediatrics in 2011. And what they essentially found was that the odds ratio of the neonate doing well or not doing well wasn't really changed by adding in the information from an abnormal aEEG background. And you can see that by the p-values listed there. So whether or not there was an abnormal aEEG didn't give much information above the exam. And for that reason, some hospitals have just decided not to use it at all to identify cooling patients. But why would you get a false normal? Why does that happen? Well, there's a couple reasons, and most of them have to do with artifact. So you remember I told you the Amplitude-Integrated EEG, what it tells you is over time, it squishes up a time period of a few hours into a page, and it only tells you the amplitude, the height of the brain waves. And there's lots of things that can make that signal look normal even when it's not. So here's an example at the bottom of the screen where this initially looks like an okay tracing. The lines are quite high. It means that the amplitudes of the brain activity were essentially normal or near the normal range. But that little red arrow there, that's when they paralyzed the baby. And you can see that after that, the brain activity is recorded as being very low voltage, very suppressed. So why would paralyzing a baby change their brain activity? Paralytics don't affect your brain activity. Well, it's because it wasn't recording brain activity on the left-hand side. That was actually a baby who was shivering. And babies who are shivering have electrical activity going on in their muscles while they're shivering, and it can transmit to the scalp. That can be recorded by the Amplitude-Integrated EEG, and it can falsely elevate the activity that you're recording. So if you just glance at the screen, you say, great, the baby's doing great. They're shivering, their brain activity looks fine, but actually their brain activity isn't fine. It's just that the recording is not accurate. You have this artifact polluting it. There have not been good large series to determine how frequent this is. There have been multiple small case series reporting these findings, and it's been consistently reported in multiple studies, but we don't yet have a large study across many centers to know how often this is a problem. So it certainly could vary from center to center. But at least in a series of 17 babies, again, very small number, with HIE in the first 6 hours when they did their aEEG, 17 of them had normal aEEGs. Only 4 of those 17 were truly normal. A much larger number had falsely normal recordings because of muscle artifact. Here's some other examples of how artifact can pollute the aEEG recording. So on the left-hand side at the bottom, you see an aEEG, where the y-axis, you can't see the numbers, but this is an appropriate amplitude for a term neonate, and it looks like it's appropriate for the whole time period. But when you look at the top at the EEG, you see there's something clearly different happening in one of the channels. And if you go to the full EEG, that's electrode artifact. If you have one of your electrodes that starts to come off of the scalp, that's what it looks like. So again, in this case, if you only looked at the aEEG, you would think that baby's doing great. But unfortunately, it's an artifact. Here's another example of aEEG artifact. So up at the top, you have an amplitude-integrated EEG with voltages that seem to be within a normal range or a mildly abnormal range. But actually what we were recording in that baby, these waveforms here, that's EKG artifact. It was a baby whose brain activity was so severely suppressed that what we were actually recording was EKG, electrical signal from the heart. That was the only thing that the EEG electrodes were picking up. So Amplitude-Integrated EEG, one of the uses is to identify patients who might benefit from cooling. I think it's a great technology, and there's data to support its use for including babies into cooling, but do use caution before excluding babies from cooling based on aEEG. What about seizure detection? This is probably the most popular use of amplitude-integrated EEG, and that's because neonatal seizures are really difficult to diagnose. Sometimes you're lucky. Sometimes you see the baby shaking away in the cot, and you know that baby's having a seizure. But sometimes you just see some lip smacking. Sometimes you don't see anything at all. And in fact, of neonatal seizures, over 85% of them do not have clear clinical signs. If you're just looking at the baby to know whether or not the brain's seizing, you're going to miss most of the seizures. Of babies who have seizures, a third of them will only have subclinical seizures. And this is what gets at that recommendation to do brain monitoring in babies with HIE. We know that of babies who have HIE who get cooled, about half of them have seizures at some point, and a third of those babies only have subclinical seizures. You wouldn't know if you weren't monitoring them. The flip side of that is that a lot of funny baby movements are not seizures at all. Babies shake, babies twitch, babies are jittery, they have mouth movements, and the aEEG can be incredibly helpful for helping to suss out, no, that's not a seizure. We're not going to give more medication for that. We're just going to stay on what we're using. Another challenge with neonatal seizures is that once you give the medication, you can suppress the outward signs without actually stopping the seizure. And so you really need to have some help if you want to have the most accurate treatment possible. So this is what amplitude-integrated EEG showing seizure looks like. You can see here something different happening every few minutes in that left side of the panel. That's what a seizure looks like. You have a sudden elevation in the amplitude of the waveform, and so you have a jump up in that bottom margin. And here they give some treatment, and the seizures go away. How good is it? It's better than relying on clinical observation alone, but it's not the gold standard. The gold standard is full array continuous EEG left on recording for 24 hours or more. So if the question you want to answer is, did this baby have any seizures over the last 24 hours, you're going to be able to identify anywhere from 60 to 90% of babies with seizures using just aEEG. And that range is a bit wide because it's largely dependent on user experience. It's also partially dependent on where in the baby's brain the seizures are coming from. But if you're trying to answer the question of, did I catch every single seizure that baby had? Well, amplitude-integrated EEG isn't going to be as good for that, and that makes sense. If one screen's showing you 3 hours of time, it's not going to be as sensitive as if you're going through every second of brain activity as you do in conventional EEG. Again, artifact is a big problem, and sometimes people mistake artifact for seizures, so you do have to be wary of overdiagnosis. So here's an example of when you might miss a seizure on amplitude-integrated EEG. Up at the top, that's what the seizure looks like on EEG. You have this repetitive abnormal waveform going over time, but on the bottom where the arrow is, nothing really stands out. And it's because this seizure didn't have amplitude that was different than the surrounding brain activity. Sometimes padding might look like a seizure, so here there was a little bit of increase in activity, but when you look at the EEG, it was just padding. It's a change in activity that you pick up on the electrode that starts and stops, and so it's a good mimic of seizure without actually being seizure. So aEEG is useful for seizure diagnosis. It certainly is much more helpful than just relying on clinical observation alone. We know that babies being cooled are at high risk for seizures. About 40% of them will have seizures in the first 72 hours. It's not a perfect tool, but it's a useful tool. The last reason or indication for using amplitude-integrated EEG in cooling is for prognosis. And we have more and more data about this now. So how useful aEEG is depends a little bit on the question that you want to answer. If your question is, can I be certain that this baby is going to be normal? Well, if your aEEG, if your brain function, your brain activity is already normal in the first 24 hours, you can be pretty confident that that baby is going to do well long term. At the other end of the spectrum, though, if your question is, am I fairly certain that this baby is going to do poorly? And this obviously comes up when trying to make decisions about whether or not to continue with intensive intervention. The initial aEEG is not as reliable, and you do have to wait a little bit longer because the aEEG can normalize in the first 72 hours. And so, again, the timing of how you use the aEEG depends on the question you want to ask. I'll have a few more slides. So this just illustrates that point that in babies who do not receive cooling, that's the red line, the aEEG is equally predictive pretty much the whole course, over 72 hours. But the blue line is babies who are being cooled, where in fact it's not as predictive in the first day. You have to wait until after 48 hours to get the best predictive value. And this is another figure representing that if your question is this baby going to be normal, and you have a good aEEG at the very beginning, your sensitivity is really quite good. It's close to 1. If your question is this baby going to be devastated, you get your best specificity, that's that green arrow, by waiting until the full 72 hours. You have to wait, you have to be more patient to have certainty about that question. For the sake of time, I'll just go ahead to the next section on that prognosis. Sleep-wake cycling is another thing you can see on aEEG. It looks like this. So when you fall asleep, you have a difference in your brain wave pattern as compared to when you're awake. As you might expect, you have to be pretty healthy brain-wise to have normal sleep and awake. And so babies who have this pattern during their first 72 hours, that's a good prognostic sign. Another indicator that people look at is how long did it take for your amplitude-integrated EEG to normalize? And as you might expect, the time to normalization, which is on the y-axis here, is a pretty good predictor of how babies do at 2 years. So if your aEEG normalized very quickly, then your outcome, your Bailey score was usually higher. If it took longer, then your Bailey score was going to be lower. And so to put this all together into a way that's useful for clinicians, there was a systematic review that took 16 articles examining amplitude-integrated EEG to predict death or disability. So not trying to figure out who's going to do well, but trying to predict who's going to have a bad outcome after HIE. And again, they found that of babies who are being cooled, the best predictive reliability is at 72 hours. You can't rely on that early amplitude-integrated EEG. You have to wait until 72 hours. For predicting which babies would do poorly, the specificity was 0.97. That's quite predictive. The likelihood ratio was 24.3. That's a pretty good test. This is a figure from a different systematic review where they pooled data from multiple studies and looked at the post-test probability. If you had a bad amplitude-integrated EEG, how likely were you to have a bad outcome? And they looked at it at different time points. And again, at 6 hours, well, it wasn't so good. Your post-test probability was only 59%. If you had a bad aEEG, only a 59% chance that you were going to have that bad outcome. But if you wait until 72 hours, then it gets up to 96%, where if you have that bad amplitude-integrated EEG, you can say with a fair degree of certainty that that baby's going to have a poor outcome. And that was data that came from 520 subjects across 9 different studies. There's this meta-analysis, which similarly showed sensitivity and specificity that were not so good at 6 hours, but after 48 hours, much improved. So how can we use amplitude-integrated EEG for babies who are being cooled? You can use it to identify which babies might be eligible for cooling because it's going to give you a measure of brain function, and it might show you more clearly than your exam that a baby is encephalopathic. But I would not advise using it to exclude babies from cooling because of the frequency of artifact, like we saw. It's a useful adjunct for seizure detection. Babies being cooled, about 40% of them have seizures, and it's going to help you in recognizing what's seizure and what's not. And then it is useful in prognosis, but you have to know what question you're asking. It's useful for identifying which babies will do well if it's normal very early on, and if it's still abnormal at 72 hours, then it is quite specific for an abnormal outcome. Thank you.
You mentioned in one of your indications for EEG that it helps to distinguish between seizures and non-seizure activities like jitteriness and shivering.
Yeah.
But these were precisely the two examples you gave for the false positives. So, aren't these two things a little contradictory, that these are the commonest causes for false positive aEEG, and we are using it to distinguish them?
Yeah.
How does that fit in?
That's a great point. So it's true that on aEEG you often get tripped up or trapped by shivering or jitteriness, but you also want to be able to pick out seizures. That comes from the specific pattern that you see on the aEEG. So if you just look at the aEEG, the 3-hour display, I think it's almost impossible to tell what's an artifact and what's a seizure. If you go to the EEG, the correlating EEG segment, which you can display if you set the settings right on your machine, then you look at the pattern to recognize what looks like artifact and what looks like seizure. And as you get more experience, it can be quite clear what the difference is between those two.
Excuse me?
I have a question.
Please.
No, please.
Okay. Since aEEG has a low sensitivity, can we use normal EEG for deciding which baby is to cool and which not to cool?
Yeah, so it's certainly true that conventional EEG gives you much more detail about brain function and brain activity. The problem with using it, conventional EEG, and deciding who to cool is that you have to start your cooling early. You want to start it before 6 hours. And it's rare that you have a neurologist or a neurophysiologist who's going to look at that EEG that quickly. Neonatal EEG is tricky, so even adult neurologists often don't want to look at the neonatal EEG.
The question is that all the schools agree to treat the electrical seizure without clinical. They do agree or not?
So the question is, do you treat the subclinical seizures? They're very frequent as compared to clinical seizures. Should you treat them? Yes. There are a few bodies that have now endorsed that position. So the WHO, for example, has said that if you're able to do continuous EEG monitoring, that you should treat subclinical seizures just as you would treat clinical seizures. In the States, the American Clinical Neurophysiology Society has also said that you should treat them just the same, because they seem to correlate with outcome equally. That if you have subclinical seizures or clinical seizures, either way, you're just as likely to have a bad outcome.
And they agree on the tracing? They agree on that?
They agree on using the tracing?
No, yeah. You know, the tracing, when it indicates probability of seizure.
So it depends on what sort of monitoring you're using. Continuous EEG, that's the gold standard. So that's the definition of a seizure, is if you see it on continuous EEG. There is some disagreement about, because amplitude-integrated EEG isn't perfect, how aggressive you should treat based on it. And that does differ from person to person.
Did they mention that it should be the tracing for 20 seconds, for example?
So the definition of a neonatal seizure is that it lasts at least 10 seconds. The duration of tracing, of recording, in California, it's required to do it for 72 hours, but there's not another official policy about how long to record for.
Thank you very much.